it is a hot research area. Okay, so in this presentation, I would like to discuss the gut-liver axis, which way it works, whether from the gut to the liver or vice versa, and the role of microbiome ecosystem in the development of liver disease in general and specifically in MAFLD. So is it NAFLD or MAFLD? This is not a spelling error. So it's a landscape shift. And what is the need to change the name? And also discuss the cornerstone of in the pathophysiology of MAFLD and how understanding of the pathogenesis of MAFLD would lead to novel therapies and the situation in sub-Saharan Africa and Ethiopia. So when you look at the epidemiology, this is a global prevalence of NCD. As you can see, the red color is concentrated at the usual place along the tropics, and it's densely, Africa is densely colored. And when you see obesity, we don't have much data in our continent, but I would assume it is also increasing. And when you see NAFLD or MAFLD, metabolic dysfunction associated fatty liver disease, this is a prevalence globally. Again, when you look at Africa, there are no much data except few developed countries in the North and South Africa and in the South. So this is mainly due to absence of data. Otherwise, we can see in our day-to-day clinical practice that this is increasing in our continent and in our country as well. So from WHO data, the 4 global NCDs are cardiovascular disease, diabetes, cancer, chronic respiratory disease. You can see that MAFLD is not included in this. And so the question is, while genetic being the same over the last 3 decades, the NCD and metabolic syndrome is increasing. This is mainly due to the change in eating habits, exposure to alcohol, tobacco, and drugs. But the gut microbiota has now been found to be the major environmental risk factor for metabolic syndrome in general, and for MAFLD in particular. And as you have seen, the MAFLD is not clearly included in the NCD globally as well as in sub-Saharan Africa. So as we have seen, this is a growing epidemic. Again, the NCD numbers, 600 million adults and 100 million children with obesity has been recorded in different data. But again, the MAFLD is not yet described. So what is the role of the gut-liver axis? This is, by the way, bidirectional interaction, the gut to the liver and vice versa. So the gut-liver axis is a direct connection from formation of both organs from ventral foregut, and liver receives 70% of its perfusion from the gut. This predisposing the liver to direct potentially pathogen or direct antigen from the nutrients that are ingested, and also the byproducts of bacteria. So this is really a direct challenge of the liver to foreign antigens. On the other side, the liver provides the gut with bile acids immunoglobulin A, which helps for immunity, and also the homeostasis of the microbiome in the gut. There are also different axes like gut-brain axis, which is best explained by hepatic encephalopathy in acute fulminant hepatitis and in the stage liver disease. There is also liver-gut axis and other endocrine axes, but more than all of this, the gut-liver axis is the major direct connection and bidirectional connection among the two systems, because the liver is as a crossroad connected by enterohepatic circulation, and liver, as I said, is because of this direct connection is exposed to different nutrients, microbiomes, and metabolites from the gut. And this will eventually trigger the innate and adaptive immune reaction, which will result in fatty deposition in the liver, a cascade of immune reaction due to antigen-antibody complement complex that will ignite a sort of allergic reaction that will affect not only the liver, but other organs, because this is an autoimmune-like reaction. So the role of the gut-liver axis in my field, microbiome, because of disruption of the gut barrier. Normally the gut has barrier due to cover of epithelium, two-layered epithelium, and also the microbiome itself and the gut vascular barrier. If this is disrupted by high intake of fat, protein, or antibiotics, then the pathogenic microbiome will escape and will traverse to the liver through portal circulation and release a toxic lipopolysaccharide, which will be attached to the receptor in the liver and induce immune system reaction, and that, as I said, ignite autoimmune reaction in the liver and also shut off lipolytic enzymes, and will lead into deposition of the fat in the liver. And because of this immune reaction, if it perpetuates, it will lead cascades of immune reaction. So dysbiosis is disruption of this protective gut barrier from pathogens in the nutrient and pathogenic bacteria. If this disruption occurs, then the pathogen will escape and will lead to immune reaction again. So the escaped pathogenic microbe will bind specific receptors, like receptor in the liver, and this will be recognized, and then the pump and dump will ignite the immune reaction because of the toxic lipopolysaccharide, and this will result, which is termed as metabolic endotoxemia, and eventually result in insulin resistance, low-grade inflammation because of insulin resistance, diabetes, and eventually metabolic dysfunction associated fatty liver disease. So the gut-liver-brain axis, this is an axis that will lead to hepatic encephalopathy from hepatic failure from different causes. And this has been demonstrated by fecal microbiome transplantation from healthy subject to patient with hepatic encephalopathy. And this has resulted in improvement of hepatic encephalopathy. Also, treatment of periodontal microbiome has also, in patient with clinical hepatic encephalopathy, has resulted in improvement of hepatic encephalopathy. This has also been explained by use of rifaximin and lactulose, which will reduce the pathogen microbiome and from the patient with hepatic encephalopathy, resulting in hepatic encephalopathy improvement. The same is true for enema reduction of protein and fat. So these are evidences that the gut-liver-brain axis works in evolution of hepatic encephalopathy. So the microbiome, by the way, microbiota are the organisms that live in gut, in trillions in our gut normally as commensal, and it's not only bacteria but includes viruses, fungi, and other organisms. But so it is 150-fold of our body cells, more than 150 times of our total body cells. So you can imagine how huge microbiome we are carrying normally, which are living in symbiosis and commensal with our body, and they are very useful for immune system maintenance and also for protecting us from invading pathogens, which are ingested with food and fluid by competing for nutrient and space. And these microbiome are also helpful for facilitating digestion and absorption and vitamin synthesis and also bile acid. So this is normal, but if there is disruption in this homeostasis, then dysbiosis will occur and the harmful pathogen will exceed and escape to the liver through portal circulation and will lead to steatosis or fatty liver, fatty deposition in the liver, and eventually induce pathogenic inflammation. Normally, there is mild escape through the hepatic circulation, the portal circulation, and this induces only low-grade inflammation, which is not pathologic or clinically detected. But if dysbiosis occurs, that will lead to pathologic inflammation and then subsequent complication. So just few terms. Pathobion is a pathogen, pathogenic microbiome, whereas commensal is harmless microbiome. And normally these two live in balance. When there is dysbiosis, the pathogen will exceed and then lead to dysbiosis, which is imbalance due to perturbance or disturbance from excess fat intake, protein intake, toxic, even surgery, diversion surgery like gastrojejunal bypass or hepatobiliary bypass will disturb the microbiota and eventually predispose or aggravate disease conditions. Microbiome normally will help in reducing autoimmune hepatitis and tumors. This has been demonstrated in germ-free mice in laboratory experiment. But if they are too low or even absent, like people deprived of, mice is deprived of germ, if the microbiome number or proportion is very low or even absent, this will predispose to toxic hepatitis, alcoholic liver disease, or other cholangiopathies and MAFLD and cirrhosis. So the balance is very important. Too high or too low or absence will lead to pathology. The balance, the symbiosis of microbes is a key for health. So too high or too low will predispose to different disease condition or aggravate other conditions, like a patient with viral hepatitis or other disease. When there is dysbiosis, the disease, underlying disease like viral hepatitis will progress more aggressively and will be worse. So it is not de novo genesis of the disease like MAFLD, but the dysbiosis of microbiome will lead to worsening of other underlying comorbidities as well. So microbiome, as I said, this is a new discovery or observation in scientific field, and it's an exciting research field. and they're driving various stages of liver disease, as I said, and affect the liver in causing steatohepatitis, hepatitis, fibrosis, and complications of cirrhosis. So is it the same that everybody has the same or similar microbiome? No, the answer is no. The microbiome ecosystem is variable among individuals and among countries, among danger, among gender. So this is because we acquired the normal microbiome from birth. There is some transmission in utero from mother to child, but the majority of the normal microbiome will be acquired starting from the birth. So you can imagine that a person delivered, a baby delivered normally transvaginal will acquire more combinations and abundance of microbiome than baby who is delivered by cesarean section, because during birth, some amount of vaginal secretion will be aspirated and swallowed by the neonate, whereas the cesarean section, this is not the case. So the population and the number diversity of microbiome will be different, but again, not only mode of delivery, but the environment where the neonate or the child is brought up also matters, because exposure to environmental conditions, in contrast to being brought up in relatively sterile, clean environment, will affect the microbiome, which means normal vaginal delivery and being brought up in rural-like setup is better in relation to the abundance and the proportion of various microbiome. This is based on studies from different countries, including our continent, from Malawi, Tanzania. There are studies that show children who are from Malawi and Tanzania, they have better microbiome composition and abundance compared to the Western children of the same age. So probably this can be indicate the future market for exporting fecal microbiome transplantation for treating people with who are devoid of this combination of microbiome. So dysbiosis, as I said, disturbance of the microbiome will lead to different conditions, including MAFLD, which is metabolic dysfunction associated fatty liver disease, cirrhosis, autoimmune disease, and also cancer, and IBD, celiac disease, and metabolic syndrome. So I think this is the gate for the beginning of several diseases, including hepatic, extraluminal, systemic disease. So in addition to this effect, the microbiome will help us in fermenting saturated fat, polysaccharides, alcohol, and produce short chain fatty acids, which will help for healthy homeostasis, and they also help in digestion of proteins, producing amino acids, and this is in healthy condition. They also produce gas, hydrogen, and they have signaling property as well. This is probably the future for diagnosis of specific microbiome, which is involved in a specific disease. So people are looking in different studies at the signaling properties of microbiome for screening and diagnosis of disease which are ignited or aggravated by dysbiosis. This is one of the future direction to specifically identify signaling properties of microbiome. So as I said, gut has several layers: the mucus layer, the tight junction, the villi, the crypt, the globe, and also recently the gut vascular barrier. This so during dysbiosis, all this will be disrupted. And when you look at the load of the microbe along the GI tract, you can see it increases as you go down from mouth to the anus. Otherwise, the whole GI tract has different proportion of microbiome, and there are different types of microbiome. And the colon is the largest habitat of the of microbiome. So you can see that fecal microbiome transplant will have several diverse microbiome in different proportion. So the MAFLD, metabolic dysfunction associated fatty liver, or which is it part of metabolic syndrome or is it hepatic? So it is hepatic manifestation of metabolic syndrome. It's part of the metabolic syndrome manifested in the liver. And so the definition of MAFLD is hepatic steatosis confirmed by imaging, MRI, biomarker, or histology, plus overweight, obesity, or type 2 diabetes, plus at least 2 metabolic risk abnormalities, including blood pressure, waist circumference, triglyceride, and HDL abnormality. So this is very simple, positive, inclusive definition. Steatohepatitis with overweight or type 2 diabetes, or at least 2 metabolic risk abnormalities. Very simple definition, and it's inclusive. It's not only alcohol, it's not only fat, or so it includes anything, any condition with steatosis, confirmed steatosis, and or one of the following, the associated syndrome. So alcoholic liver disease is included in this one, and other metabolic syndrome are also included. So it is an inclusive, simple definition. So the NAFLD, which was coined in 1980, has been changed to MAFLD in after 40 years, because this is etiology-directed definition. The metabolic dysfunction is the etiology, whereas in NAFLD it is simply says non-alcoholic fatty liver disease. It doesn't indicate the etiology, which has implication for treatment, screening, prevention, and so on. That's the reason why the name has been changed. So these are the associated metabolic abnormalities, as I said. So the magnitude of this condition, the MAFLD metabolic syndrome in general, has become epidemic globally, and it's the most common liver disease now, and the most common reason for transplant globally, and it's also the leading cause of hepatoma next to viral hepatitis. But in Asia and Africa, there are limited data. Otherwise, from metabolic syndrome studies, this is the major problem in our setup as well. So it is time to act now before it become epidemic or pandemic in our setup, because this is modifiable and it has multifactorial. So these factors, some of these factors can be modified, especially diet and lifestyle. So the magnitude globally, it is about 1/4 of the global population, and it mimics the global obesity map, as we have seen at the beginning, and it is a hepatic metabolic syndrome or vice versa. So is it the hepatic MAFLD is causing a metabolic syndrome or vice versa is the question. So it is both ways, the metabolic syndrome, like inducing fatty liver and then cascade of inflammatory process, and also MAFLD can lead to metabolic syndrome. So it is both ways, and it results in multi-organ infection, and So in MAFLD, among the microbiomes, the firmicutes are increased, whereas the bacteroids ratio, the bacteroids decrease. So among trillions of the microbiome, these are the major microbiome which are observed in patients with MAFLD. Firmicutes increase where the bacteroids decrease, so the ratio will increase. Another interesting point to remember is MAFLD can coexist with other conditions. In the past, we used to rule out viral hepatitis, alcoholic liver disease, and so on to say this is MAFLD. But MAFLD, if you diagnose using the criteria, you can diagnose still MAFLD in presence of other conditions like alcoholic use disorder or viral hepatitis. So it is a spectrum of disease starting from steatohepatitis, steatosis, simple fatty infiltration of the liver, then to steatohepatitis with an inflammation, and eventually cirrhosis and fibrosis. So it is a wide spectrum of disease. But it is under-recognized, especially in our continent, which is estimated to be about 30%. And in our country, it's similar that we don't have data, but we need more. And it is more prevalent among urbans, especially urban poor, who can afford the junk food that can predispose to MAFLD. So when you look at the pathogenesis, I've tried to describe previously, it's multifactorial. The genetic predisposition and metabolic factors like taking fatty, sweetie, packed food, sedentary life, and that will lead to dysbiosis and then disruption of the tight junction, and that will lead, gives a way for the pathogenic bacteria to escape to the liver and induce inflammation, immune dysfunction, and eventually will result in MAFLD. So what is the association between microbiome and MAFLD? Again, in this, there is a close association as it was seen in experimental mouse, that MAFLD is transmissible by fecal microbiome transplantation. So when the mice were, the fecal microbiome from healthy mice was transplanted to mice from MAFLD transplanted to healthy mice, they developed MAFLD. So it is transmissible, and antibiotic and probiotic have also shown to improve MAFLD in patients with MAFLD. The same is true in alcoholic patients. Patients with severe alcoholic hepatitis, when their fecal material was processed and transplanted to healthy subject, the subjects who transplanted with fecal microbiome developed severe MAFLD. So this is a picture to show, this is on the left side, a normal barrier, the mucus layer, the epithelium, and then the vascular barrier. This is the normal. But when there is dysbiosis from diet and other disturbing environmental factors, then the pathogenic microbiome will escape through the opening up of the tight junction, and then will bind to the hepatic receptors, then will induce inflammation and lead to subsequent complication. So this is an enlarged picture showing the same. You can see how complex and several chains of inflammatory process after escaping of the pathogen and inducing different immune cells in the liver, the T cells, the macrophages, the Kupffer cells will produce the cytokines that will lead to inflammatory process and eventually inflammation and complication of the. So it is through endotoxemia of from lipopolysaccharides and that will lead to not only activation of the immune reaction, but also by inhibition of all lipogenic enzymes. This is another key point that will result in or stop lipolysis and then a deposition of the lipids in the liver and eventually lead to fatty liver. So modifiers, as I said, the route of mode of delivery, the diet, the Western diet, alcohol, smoking, antibiotics, this will modify the normal gut microbiome, will lead to dysbiosis and eventually complications related. Okay, so in MAFLD, protobacteria and fusobacteria and firmicutes, these are increased, whereas the bacteroids will decrease, and the imbalance will result in dysbiosis and related complications, leading to inflammation, immune activation, and related complications. So how about the viruses? The viruses are also there, the fungi are also there, and they have also a role. Bacteriophages will be reduced in MAFLD. These are the viruses that eat bacteria in the microbiome ecosystem. So if these are reduced, then the bacteria, there will be abundance of pathogenic bacteria leading to dysbiosis and related MAFLD. About SARS, in recent studies, SARS has also, similar to this mechanism, has also shown to increase permeability of the gut and mucosa, leading to leaky gut and escape of the pathogenic microbiome to the liver, and therefore this will result in systemic COVID immune dysfunction. So it will lead to severity of the COVID as well as associated MAFLD. This has been shown. So the viruses have also key role in. Okay, so this I've already said about these layers of protection of, and this is just to show pictorially that our body is protected from these potentially pathogenic organisms through these layers of protection. So if this is disruption of the protective layer, you can see the pathogen will escape and will enter the portal circulation and reach the liver. So the bile acids, normally these are helpful, but when there is suppression of the bile acid, secondary transformation from primary bile acid in the enterohepatic circulation, then due to FXR activation, this will lead into insulin resistance. This has also, using this observation, a synthetic bile acid analog was developed, the obtacolic acid, which is now used for treatment of patients with MAFLD. So again, dysbiosis resulting in different disease conditions. How about autoimmune disease? There is association also of dysbiosis autoimmune disease because autoimmune disease, like autoimmune hepatitis, develops from genetic predisposition, immune intolerance, breakdown. Normally there is immune tolerance. Due to dysbiosis, this will be broken and will lead to or aggravate autoimmune disease. So in cirrhotic patients, if there is dysbiosis and of microbiota, this will lead to progression of cirrhosis and will lead to complications like hepatic encephalopathy and spontaneous bacterial peritonitis. Again, this is, can coexist or can complicate, and the pathogenesis is similar. So the bile acid, FXR agonists and antibiotics can influence the microbiome homeostasis and eventually will lead to bacterial translocation. So there are different factors that play in causing dysbiosis, including environmental, antibiotics and diet that will lead to dysbiosis, and this will eventually lead to escape of the bacteria translocation going to the liver. And again, relation with hepatocellular carcinoma, these studies have also shown that dysbiosis will lead to MAFLD cirrhosis hepatoma. And not only this, the dysbiosis will aggravate the pre-existing hepatocellular carcinoma from other conditions, and probiotics have been used to reduce hepatocellular carcinoma tumor cell numbers in rodent experiments. So this is probably the future of treatment of hepatocellular carcinoma as well. Other autoimmune conditions like IBD, primary sclerosing cholangitis, have been also, dysbiosis have been shown to be related with these conditions. Hepatocellular IBD alone or with primary sclerosing cholangitis. So patients were found to have dysbiosis. So it has a role in this as well. Other liver conditions, like I said, viral hepatitis, other autoimmune disease were also associated. So patients with these conditions were found to have reduced bifidobacteria, and which is leads to worsening of the underlying condition, and because of the bacterial products. So they worsen the underlying condition if there is dysbiosis. Post-hepatectomy, so different studies have also been carried out to see if there is change of normal microbiome after partial hepatectomy. So what was found was there was upregulation of more than 600 bacterial microbiota genes in patient post-partial hepatectomy, and increased bacteroids and decrease in Clostridial pathogen microbiome was observed among patients with post-hepatectomy, showing that there is a potential shift of microbiome, which will help in liver regeneration. But if there is dysbiosis due to antibiotics or dietary change, then that can impair liver regeneration as well. So the gut-brain axis in hepatic encephalopathy patients, as I said, this is the mechanism why patients develop an hepatic encephalopathy manifestation because of dysbiosis. But urease production from the kidneys, small intestine have also additional contribution. So this is just a pictorial presentation of the hepatic encephalopathy or liver brain axis. Dysbiosis leading to ammonia production and eventually hepatic encephalopathy. So this is microbiome and varieties among different autoimmune diseases like primary sclerosing cholangitis, PBC, and so on. Dysbiosis in liver disease, this is again to show pictorially in ALD, MAFLD, and autoimmune disease, there will be dysbiosis leading to these conditions or aggravation of the conditions due to dysbiosis. This picture shows the proportion of the microbiome among different liver conditions. So you can see the firmicutes are higher, where the bacteroids will be lower when there is dysbiosis, and that will lead to pathologic conditions. So based on this observation of the role of microbiome, there are interesting studies going on to discover novel diagnostics and novel therapies for MAFLD as well as other metabolic syndrome. This is so advancing by advancing sequencing, culturing, metabolomics, epigenetic genomics, fecal microbiome transplant, prebiotics, antibiotics, and synthetic bile acids, like I've said. So the future is looking for microbiome signature for using for screening, for severity assessment, monitoring of treatment response, and of course, novel therapies in addition to what currently being used, FMT, prebiotic, and probiotic. Probiotics are bacteria that are used for repopulating of the disturbed microbiome, whereas the prebiotics are undigestible chemicals that will help the microbiome to restore. So the novel therapy, probiotic, rifaximin, FMT, these are currently being used for MAFLD and other liver conditions like in hepatic encephalopathy. And fiber diet, of course, will help in restoring short-chain fatty acids, reducing body weight. Vitamin D has also antifibrotic effect in addition, based on the previous observations. So another important thing to remember is there is a new substance used, VS01, which instilled into the patient with, which is used in a patient with ascites due to CLD, and this will help absorption of ammonia. Patient with CLD, hepatic encephalopathy, this VS01 and installation into the will be absorbed from into the cells, and therefore the ammonia produced in the body will be contained, and this is will have therapeutic advantage in a patient with hepatic encephalopathy. It will be trapped into the cells. So the gut immunity and MAFLD relation. The gut immunity will help in homeostasis normally, in keeping the tolerance, the immune tolerance balance, and otherwise, if this is disturbed from different dysbiosis causes, that will lead to disease. Normally, the gut immunity will maintain, in addition to the barrier, will maintain the homeostasis, immune homeostasis, keeping the tolerance of the immunity to different external pathogen. So screening of MAFLD for risk factors. Clinically, most patients with MAFLD are asymptomatic, and usually they are detected late.
Sorry, we have lost Professor Dr. Amir.
MAFLD. Can you hear me?
Yes, yes, Professor, you can proceed.
Thank you. So screening of patients with MAFLD clinically is difficult because most patients remain asymptomatic, but there are different tools now that we can use to screen patients. The first thing is identifying high-risk patients for metabolic syndrome in general and MAFLD specifically, and then laboratory tests that will help for detecting, screening metabolic syndrome can be used. Also imaging like MRI ultrasound is not very specific to identify patient with MAFLD, but MRI scope is useful. And And so, and we can also use non-invasive scores like a PDE4 to screen patient, and currently fibroscan elastography is also very helpful to pick patient with early fibrosis before they progress to. Okay, so regarding treatment, although there are promising novel treatments, the current treatment we have is MFT, fecal transplantation, insulin sensitizers, but others like symbiotics, omega fatty acids, and so on are not confirmed to be useful. So what we have is to work on prevention, because this is preventable by modifying environmental factors. And of course, if there is advanced to chronic complications, liver transplantation will be the last option. So we have to emphasize on prevention. Prevention starts from choosing the route of delivery. There is a tradition of moving toward disease, but these different studies have shown that normal vaginal delivery is preferred for subsequent better healthy life. Neonatal infancy or infancy, use of repeated use of antibiotic will make someone also devoid of useful microbiome. So it's not recommended to use antibiotics repeatedly during infancy or neonates. And also regarding food, sweet, saturated fat, ultra-processed food should also be discouraged, including the advertisement for this alcohol and smoking the same. And sedentary life should also be avoided. We should make exercise the habit to prevent this major alarming epidemic, MAFLD and metabolic syndrome. Secondary, we should not forget that MAFLD can be also caused from secondary causes like viruses, hepatitis C, HIV, and drugs like amiodarone, tetracycline, and heart and surgery, bypass surgery can also potentially predispose someone to MAFLD. So we should be alert to look for MAFLD in this scenario. So the recommendation is to integrate MAFLD metabolic syndrome into primary healthcare system, including the NECD program, and like programs like viral hepatitis, HIV, malaria, TB. These are already in place, and we should try to integrate this into these existing horizontal programs. Making MAFLD as part of NECD program, and also using network like eco telemedicine to work on this prevention. And there is also now the World Liver Health Day, June 12th. We can use this day as promotion of increasing awareness and promotion against MAFLD, which is going to be another challenge for us. And also using formal and social media to educate people and professional and the community as well, and using community and political leaders also to advocate as ambassadors for MAFLD. So in summary, GI liver are not only the biggest, they are not only the biggest and busiest organs, but they are the gate for our health or disease. So we have to be proactive rather than being post-active, which means we have to look for and try to prevent risk factors and look for secondary causes of MAFLD, as MAFLD is the most prevalent disease in the world now, probably leading to novel diagnostic and therapeutic armamentarium, not only for liver condition, but extra hepatic conditions as well. The gut-liver axis disruption is a key entry point for all this, and we have to remember that, try to maintain to prevent the disruption of the microbiome ecosystem, especially using the diet, which is modified risk factor, and MAFLD is
multi-organ disease. Is it MAFLD causing metabolic syndrome or vice versa? It's like chicken and egg relationship, but it is possible both ways. The situation in our setup, as I said, the data is scarce, both in Ethiopia and including sub-Saharan Africa in general. So we have to work hard to generate data and work on prevention and emphasize on integration of MAFLD into the horizontal programs, and also multidisciplinary approach, using multidisciplinary approach, as this is a disease which is a multi-system disease affecting multi-system. So hepatologists, endocrinologists, cardiologists, and others, we should work together. And the message I have is leave nature alone and live longer and healthy and peacefully. Thank you very much.
Okay, thank you, Professor, for this very interesting and informative lecture. So, so for the sake of time, let us give a few chances if there are any questions or comments. If not, so can you say a few points on the pretest case, Professor?
Yes, the the pretest answer, I think, shows that this was important to discuss. And the first question, to which of these will be the patient be more susceptible in later life? I think, as you can see, this patient who was brought to Addis during infant neonate is going to probably most likely formula milk fed and exposed to CT conditions, including junk food and so on. So you can understand that the comparison between the two, his twin brother in the rural and the patient, they are completely different. This has also been observed in different studies. And therefore, because of this poor microbiome ecosystem, this person will be predisposed to dyslipidemia, to MAFLD, to diabetes because of insulin resistance. NASH is just an extension of MAFLD. This is an inflammatory stage. MAFLD is inclusive from fatty liver to end-stage liver disease, cirrhosis, and so on. So it's the patient will be again predisposed to NASH, and of course cardiovascular disease as because of cardiometabolic syndrome. So the answer is number 7, which is all. This was confusing because, as I said, this is a new era, and you can think of different ways. And I hope try to pass the information that it would have been nice to see also the post-test, but it was not done, and hopefully.
So I have shared the results. So 73% have responded all for the first.
So it is better than the first one?
Yeah.
Okay. Still, we need to read more. So 73 is not bad, but I expected better because, as we said, the difference between the microbiome ecosystem in this two settings is completely different, and the exposure, potential exposure to food and formula diet and so on will disturb the ecosystem of microbiome. If that is the case, dysbiosis will result. And once dysbiosis results, then of course you are predisposed to all these conditions. And the second question, which factor could contribute to his anticipated later life disease? So the powdered milk consumption, fast and packed food, polluted air, antibiotics. So the answer you can guess from this is 1, 2, and 4, because this will disturb the ecosystem again, the microbiome. So the answer is 6 for the second one. Thank you.
Okay. So 91% have responded correctly for this one.
Okay.
Yeah, that's wonderful. So I think for the sake of time, thank you, Professor, so much. So we'll end up our morning session here. Have a good day, everyone.
Thank you. Thank you.